friends, respected chairpersons. I'd like to thank the organizer for giving me an opportunity to make presentation on HIV-2 infection, something which was never ever thought before 1990. And I hope Dr. Gilada remembers that we had a conference with you, and then we had a German best of the virologist lady. Gilada gives me a phone at 9 o'clock and says that she's coming to GT hospital to collect some 30, 40 samples. Luckily, we had about 50 indoor patients, and we collected the samples. And to her surprise, to the surprise of the world, we found that HIV-2 is something which is also a problem in India. What was thought was, it was identified first in 1986, and the West African countries are the epicenter for HIV-2. But because of the civil war and migration, the whole thing is spread to French and Portugal connection countries, to Europe, of course India, the Goa being a Portugal connection, and it has also gone to the USA. People say that HIV-2 incidents are getting lower, probably because of the low infectivity, in contrast to people claim HIV-1 epidemic is stable, increasing, decreasing is a matter of controversy. HIV-2 are of A to H types, but only A and B are supposed to be human epidemic responsible. In India, our study has shown HIV-2A type as predominant. And this is the publication we had way back in 1991. And this is like people claiming in other part of India that they discovered HIV-2, but this is one of the original discovery sort of published in Lancet. What are the modes of transmission? Of course, heterosexual transmission, but it's much lower transmissibility as compared to the HIV-1, something like 5 to 10 folds lower. And same way, vertical transmission is very low, 20 to 30-fold lower. And of course, other transmission routes are homosexuality, blood transfusion, and IV drug usage. The lower infectivity of HIV-2 is most likely because of the low viral load. HIV-2 is less infectious than HIV-1. It is less pathogenic than HIV-1, and we'll show you the mechanism. It is a much, much longer asymptomatic phase, maybe 10 to 30 years, and probably some never develop AIDS during their lifetime. It's a question. I have patients who are not yet ever developed symptomatic HIV infection. However, once the immunodeficiency advances in HIV-2 infected individuals, they have a similar high mortality as the study from the Gambia shows. Why two viruses, HIV-1 and HIV-2, have a distinct natural histories? Nobody knows. Although differences in immune activation or viral protein may play a role. What was the study shown somewhere from US that HIV-2 infection protects against HIV-1? That's not true. We have cases of both HIV-1 and HIV-2 infection. Possible mechanism for lower pathogenicity of HIV-2 is viral factor, less efficient replication of HIV-2 in vivo, host factors, more robust innate immune response to HIV-2, or most robust adaptive immune response to HIV-2. Clinical manifestations. Somehow or other, I have something like 65 HIV-2 patients in something like 27 years. And what we see is, of course, the prolonged asymptomatic phase. And the CD4 count declined very slowly. And when they decline, then you have a similar illness as those of HIV-1. Most of the infections are similar, like tuberculosis, esophageal candidiasis, Westing syndrome, disseminated MAC cryptococcosis, cryptosporidiosis, CMV disease, Kaposi sarcoma, certainly not in India, age dementia complex, recurrent bacterial pneumonia, and PML. But what's most important is you also see something like uncommon findings that you not see in HIV-1 and that you see in HIV-2 is a multiple cranial neuropathy, non-immune thrombocytopenia, and lymphoma. Encephalitis is far more common in HIV-2 individual because it's a neurotropic virus as compared to HIV-1. HIV nephropathy is much less common. The African study shows, the several West African studies shows there are no much major differences. But what is most important is Kaposi sarcoma is lesser. In a countries where Kaposi sarcoma is so common in West Africa, it is lesser in the HIV-2 infected patient. Most important point is HIV-2 infected individuals had a higher CD4 count even when they were diagnosed symptomatic and consequently low mortality because the treatment was initiated. Testing, I think this is extremely important. I mean, the mystery of how I picked up 56 cases who are under my care is important thing is the high index of suspicion. HIV-2 infection should be suspected in a country like India, wherein clinical manifestations are very much suggestive of HIV infection, but you have HIV screening test positive and indeterminate Western blot. I'm going to show you some of our laboratory findings. Initial HIV testing, which is positive, as you do normally nowadays, HIV duo test, then should be subjected to the differentiation between HIV-1 antibody test. And anything that is serologically reactive should be subjected to the confirmatory test. We perform HIV-2 Western blot by Metropolis Lab, which is our kind of a collaboration. Some people do immunoblot tests. I had no idea on that. Approximately 1/4 to 1/3 of HIV-2 patients without ART, and when they are symptomatic, have HIV-2 viral load below detection. That is something a big mystery. And some of these patients will have a clinical progression, CD4 count decline, but HIV-2 viral load not detectable. There are no validated HIV-2 genotypic or phenotypic resistant assays available as it has been recommended for HIV-1. And this is an algorithm of how you suspect HIV-2 infection when you see a patient with a screening positive, indeterminate Western blot test, and then you think of doing HIV-2 Western blot screening. There's nothing like PCR for HIV-2. Now we have it available at the Metropolis Lab. This is one of the examples where a patient has obvious symptoms suggestive clinically of HIV infection, but there are hardly few bands seen and HIV-2 indicative as per general Western blot screening. And then we did a Western blot HIV-2, we find all the bands positive. When to start treatment? It's advisable to start antiretroviral combination therapy in HIV-2 patients earlier than HIV-1 positive individuals. If you have a chance and if your patient is HIV plasma viral load more than 1,000, it should be treated. The French people have the largest HIV-2 cohort, very well worked up. Of course, the Western Africa countries have a big number, but these are all well worked out. Recently, I came from Paris just 4 days ago, and I met a person who is in charge of French HIV-2 cohort. They say they have every time revision of guidelines to start treatment. Most of the symptomatic patients who are HIV-2 positive should be treated irrespective of CD4 count or viral load. All the HIV-2 pregnant women, of course, should be treated like HIV-1. Asymptomatic patient with CD4 count less than 350, you must treat, but if you're somebody who is less than 500 CD4 count, should be initiated treatment. How about antiretroviral drugs in HIV-2 infection? Of course, you can't use NNRTI because they are intrinsically resistant to infection, and to susceptibility, and then of course T20, the drug which was very well used in a drug-resistant HIV, T20, we probably had hardly any experience here. It is sensitive to currently available all the nucleoside reverse transcriptase inhibitors, although these drugs have a lower barrier to resistance than as compared to HIV-1. The protease inhibitors of choice are boosted darunavir, lopinavir, boosted, of course, boosted saquinavir, as compared to other protease inhibitors. The other protease inhibitors like atazanavir, which is very famous drugs here, boosted atazanavir, should be avoided because of their lack of ARV activity and high failure rates. I don't have much idea about boosted enginavir people claim should be used in a people who develop first-line failure, but then the toxicity should be monitored. Integrase inhibitor, raltegravir, is supposed to be good in management of HIV-2 infection. If you can afford it, I would reserve it for a failure patient. Of course, they say darunavir and alveltegravir as susceptible. Maraviroc, yes, it works in HIV-2 infection. How do you manage patient, what are the drug of choice? You can use either tenofovir or azet combined with APTC or 3TC with a boosted lopinavir to start with. I mean, some people like boosted darunavir, I would reserve it. If your patient is failing, the second-line drug is if you use a boosted lopinavir with 2-NRTI, you'll have to add saquinavir boosted with raltegravir or boosted darunavir with raltegravir. I'll show you our experience to the resistant HIV-2 infection. The World Health Organization recommends almost a very similar thing. They thought in terms of using triple nucleosides, but we are not very happy about the potency. Otherwise, the same treatment as 2-NRTI with boosted lopinavir. Monitoring, difficult. There is nothing like HIV-2 viral load FDA-approved kits, but we have now HIV-2 viral load available, and the response is normally monitored clinically and assessing CD4 count. The best important thing is that CD4 response in HIV-2 infected patient following antiretroviral therapy is much lower as compared to HIV-1. Treatment failure despite the baseline HIV-2 viral load being undetectable is not uncommon. We have experienced it. And the viral response to ART is significantly lower than it is seen in HIV-1. It's a very complex issue. I think somebody has to be very much focused on HIV-2. From West African studies, they have found in Senegal emergence of HIV-2 drug resistance. We reported earlier than them. This is 2009. I had a fortune to have the anterior drug-resistant HIV-2 infection patient. All these patients' samples were processed in Paris, one of the best French reference laboratory. There's nothing that I could do it here. I had to get it done there, and patient on multiple drugs. Parental transmission. My first HIV-2 case at GT Hospital had a mother who delivered HIV-2 positive baby. And what is it? Compared to HIV-1, HIV-2 is less transmissible from infected mother to child. HIV-1 transmission rate is 20 to 45%, globally it varies, versus HIV-2 transmission 0 to 5%. This is what our West African study shows. Of course, you'd never ever give nevirapine prophylaxis, which is almost outdated during pregnancy. Triple combination, once you see HIV-2 positive woman who is pregnant, should be as usual tenofovir or AZT with FTC or 3TC and boosted lopinavir. And this is the one who definitely like to reduce the transmission. I also have 7 patients of HIV-1 and HIV-2 co-infection. Again, it's an art to pick it up. That's something which is very important. In West Africa, there are 0.3 to 1% people who are co-infected with HIV-1 and 2. The mortality is the same amongst the people who are dually infected or HIV-1 only infected. Treatment, Now, patients, they should be treated with boosted PI, no NNRTI, and 2 NNRTI. If you have a resistant development, then you do a resistant assay and decide the treatment line. This is the patient who's under care for about 6 years on anterior therapy, falling sick and falling CD4 count with a viral load below 20. And then I thought of doing a simple Western blot, and I found HIV-1 positive, but HIV-2 indicative. Then I did an HIV-2 Western blot, and it was positive. So this patient was dually infected, and they changed the treatment. And this all happened because the patient was on tenofovir, Aptis-C, and efavirenz. Summary. HIV-2 infection is endemic in West Africa, limited worldwide spread. Compared to HIV-1, HIV-2 is characterized by much longer asymptomatic stage, low plasma viral load, slower decline in CD4 count over a period of years, lower rates of mother-to-child transmission, lower genital shedding, and lower sexual transmission. However, a significant proportion of HIV-2 infection progress to AIDS. HIV-2 is intrinsically resistant to first-generation NNRTI. And the newer generation of NNRTI could be working on, or the response to HIV-2 may be partially resistance to PIs, some of them, and has low genetic barrier to NRTI resistance. Thank you a lot. This is just to show you our number of publications, on HIV-2 collaboration in India. Oh, can I have the slide? No. All right, no problem.
Thank you, Dr. Maniar, for this excellent overview of HIV-2 infection. Very interesting. May we ask the audience if there are any questions?
Thank you, Dr. Maniar, for your excellent presentation. In this reference, I have presented on paper 7, Murugan, yes. So we have presented...
Mike, I can't hear you.
In this reference, my paper is also included in the 7. We have presented, I have come across more than 20 HIV-2 cases. Now 6 cases were under my follow-up. I want to register one more observation. The immune recovery in HIV-2 patients is very much less compared to HIV-1. Even after years of ART, the immune recovery, the CD4 count recovery is not more than 250 to 350. Whereas in HIV-1, we can see up to 900, 800. Recovery is very better, very much better when compared to HIV-2. Thank you.
I think I have the same or similar observation. And in your index of suspicion, that point should go when the patient is not responding immunologically. Despite viral load is controlled and CD4 counts are below 200, we suspect HIV-1 and 2 and we find it. And what we have seen also that over the years, initially it used to be about around 2% of the patient HIV-2 and 1 to 2% HIV-1 and 2 combined. And over the year, as transmission of HIV-2 is less and less, we are not seeing more than 1% of the newer patient as HIV-2.
Sure, I agree with you.
Sir, which of the drugs are effective for HIV-2? Stavudine, lamivudine, or tenofovir? Which is
you said, yeah, tenofovir, fine. Azet also fine. Okay. Nowadays, nobody uses D40, but it was being used before. Yeah.
And combine it with the protease inhibitor, sir?
The protease inhibitor, first line choice is boosted lopinavir.
Okay.
There are some people who want to use boosted indinavir 400, 100, or 800, 100 per day. Listen, we talk of raltegravir. Why don't you reserve for second line drug? Our patient can't afford raltegravir as a first line treatment. People talk about the same way for HIV-1. Let's reserve raltegravir.
Good morning, sir. Is there any light at the end of the tunnel for the viral load estimation of HIV-2, sir?
Sorry?
HIV-2 viral load.
Yeah.
Is there any light at the end of the tunnel? Is there any progress of...
Whatever the viral load assay we have got available at Metropolis is one of the American. Now they have FDA approved viral load just recently marketed. But so far, it's just working well. Previously, it was below up to 900 copies. Now it's below up to 40 copies we can measure. They do it at Metropolis. Maybe some other laboratories must be doing. We don't use a home-brewed PCR. Again, a lot of mashup. If you're trying to attempt to use home-brewed PCR, you have no control data on that. Yeah, Ishwar?
This is only to share with all of you that in 2000 World Conference in Durban, I had presented a paper on HIV-2 and HIV-1 cases in Bombay. Out of about 350 patients, 8 were purely HIV-2 and 6 had dual infection. That's all I wanted to share.
Yeah, sure. See, one thing which is very important is that in the ART center, they're only the screening test for HIV-2, saying that this is HIV-2 positive. I mean, you have to have the Western blot confirmation. But there's something like a lot of cross-reactivity between HIV-1 and 2. Before you're sure that this is an HIV-2 infection, you have definite validation to be done. I mean, because it does matter a lot, because the prognosis prediction depends on your confirmatory evidence for HIV-2 infection. Yes?
Sir, I have 2 questions. Is any significant role of viral load in HIV-2 patient? If it is not, then what are the points on which we decide it is the time we should switch the HIV-2 infected patient?
Can I have the presentation? Yeah? Can I have the presentation? I think I clarified to you on this. Can you project? प्रोजेक्ट है ना यार हाँ तो कैसे मालूम पड़ेगा oh you think it is you seen okay I think I made a presentation when to start treatment and Paul mentioned that you're talking of starting treatment.
No sir, switch.
Oh, you're talking of monitoring.
What are the points on which we decide it is the time to switch the patient?
Excuse me. The treatment should be started in obviously all symptomatic patient or somebody whose CD4 count is less than 500, all right? So, in fact, I would say that if your CD4 count is somewhere less than 500, you start it. You don't have to have viral retip. There are a lot of patients who are symptomatic, falling CD4 count, HIV-2 viral load is not detectable. It's something very peculiar in HIV-2 infection. You need to start. I won't be surprised. The recent meeting of mine with the French cohort at Paris was saying that why you want to delay it? Let's start treatment in a patient who is already diagnosed with HIV-2 rather than wait for inflammatory process to progress and produce various damage to the vital structure of the body. The monitoring is obviously clinical and the CD4 count, because the viral won't be very high even if you have an age-defining illness. I think you do get used to, whatever patients I have on treatment, out of 56 patients, only 20 patients of mine are on treatment. Most of them have CD4 still around 900, so I'm just waiting and watching them. Thanks a lot.